Recently, Dr. Barrett and I sat down for a discussion on underwater diving and cardiovascular disease, which is our next topic on ACCEL.
Dr. Bove, I understand you have an extensive background in diving. Tell us about that.
Let me just say, first of all, that this area is an area of interest. It's been an area of interest to the military for a long time in the area of submarine and diving medicine. And there's a large group of commercial divers that work in harbors and in particular in oil recovery. And there's also a large number of recreational divers throughout the world. And I guess what I think we ought to concentrate on today is a little bit about recreational diving, because they're the individuals that might show up in a cardiologist's office. My own background is training in the Navy and submarine and undersea medicine, and I've stayed involved in this area throughout my career to the point where I'm board certified in undersea and hyperbaric medicine and author of a textbook and do a lot of education in this area.
What are the major effects of sport diving on cardiovascular function?
I think what everybody sort of conceives of is a sort of a mysterious world where, you're underwater and things. But the real issue is exercise. It's just as though somebody is asking about playing tennis or maybe participating in a foot race around the neighborhood. But the same issues come up. Can you tolerate a certain level of exercise? This has been studied in all the areas, sport, commercial, and military. But in the sport diving area, I think one would see usual sport diving in comfortable circumstances to require 2 or 3, 4 minutes of exercise, not a lot of exercise. This would be equivalent to walking at about 20-minute miles. But then in this environment, the one thing that's different than most others is there's sometimes where you can't control the environment and it becomes more strenuous. There may be wind, there may be sea surfaces, there may be currents that you have to swim against. So I generally recommend people have a tolerance of about 6 METs to be able to handle some of these contingencies that may come up and may compromise safety if you can't deal with that. So I would say from the standpoint of assessment of capacity, around a 6 MET capacity is the safety zone, and a 3 or 4 MET capacity for what you'd normally do in diving is where we ought to aim. So if somebody comes to you for a clearance for diving, let's say, and this may not always be in a cardiologist's practice, but it could be because of specific cardiac issues, the first question is this individual healthy from the standpoint of cardiovascular risk? And particularly over the age of 40, the first thing I ask is, what is the risk? What is the cholesterol? Is there blood pressure problems? Does this individual smoke? It's the same that you'd ask if this person wanted to do any other kind of strenuous exercise. That's the first thing. Assess risk, make sure this person is not at risk. Because we know what the work levels should be, you can put the person on a treadmill and be sure they're safe by putting them up to an exercise level that would suggest they can handle a 5 or 6 MET steady state load. Short of that, any other cardiovascular abnormalities need to be considered on an individual basis for the way they could interact with the undersea environment.
What do these cardiovascular effects mean for our patients with coronary artery disease who want to dive?
Let's just look at some of the things that we encounter every day. Coronary disease by far being the most common. Obviously, the exercise demands for diving are similar to, let's say, playing a moderate game of tennis. And under those circumstances, what you'd like to be sure of is that the individual is not developing ischemia at, let's say, a 6 or 7 MET workload. That's about a stage 3 on the Bruce protocol, somewhere in that range. So you want to make sure somebody can handle stage 3 on a steady state basis with no evidence of ischemia or arrhythmias. So the first step is look at risk. If somebody has coronary disease, if they've had a stent or if they've had bypass surgery, and I will say there are recreational divers who have returned to sport diving in a controlled environment after bypass surgery and after valvular surgery and after stenting, as long as they can handle that workload without ischemia. So that's coronary disease, and it'd be the same thing that you would do if a person came and said, I got my stent, I'm fine, I want to go out and play some tennis, is it okay for me to do that? And you'd do a stress test to make sure there's no ischemia. So it's pretty much the same process for coronary disease.
What about for our patients with heart failure?
A person with a cardiomyopathy has some interesting, unique issues because, first of all, water immersion in its own right causes some fluid shifts centrally. The physiology of that's been well worked out. But if you or I or anybody goes into a swimming pool and gets water immersed up to the head or up to the neck, there's about a 600 or 700 mil shift of blood volume into the central circulation because of the pressure pushing blood from the venous system up into the chest. Somebody that's got decompensated heart disease with decreased left ventricular function can develop pulmonary edema and congestive heart failure. And actually, this has happened in some cases where an individual with heart failure, presumably well controlled, goes into water, whether it's diving or snorkeling or swimming, and goes into heart failure because of this fluid shift. So that's one thing that has to be at least understood, because this will happen in people with decompensated left ventricular function. Short of that, if LV function is reasonable, above, let's say, 40% ejection fraction, they can, in fact, probably do some very easy sport diving if they want to. I generally tell these people to go to a swimming pool and go in and swim, because the same environment will occur with the water immersion. If they can handle that, they usually can do some very easy diving.
And what about our patients with adult congenital heart disease who want to dive?
Couple of interesting problems here. First of all, this fluid shift can get those individuals in trouble with significant volume shifts centrally if the heart has shunting, or let's say a Fontan patient might have a significant rise in central pressure and have some problem from that. There's a couple of issues with shunting. Now, diving is interesting in that we have this entity called decompression sickness, which is the result of bubble formation in the tissues and blood if a diver doesn't follow prescribed protocols for ascent to the surface. Under the circumstances, there's venous gas emboli, and venous gas emboli normally would be trapped in the lungs and dealt with that way. But if obviously there's a shunt, the venous gas emboli can cross into the arterial circulation and embolize into the brain and other areas of the systemic circulation. The big issue that comes up there is anybody with cyanotic congenital heart disease wouldn't be able to handle the diving environment because of all these physiologic changes. One of the big issues that comes up is a patent foramen ovale, and there's been much literature on PFOs, as you know, with stroke and with migraine, and also in the diving world because of this concern for venous gas emboli being able to bypass the lungs and get into the systemic circulation. I've had many queries regarding qualifications for diving with a PFO, and let me say from the outset that a PFO is not a contraindication to diving, whether it's sport, commercial, or military. The incidence of diving-related events is very low. If you think that 25 to 30% of the entire population has a patent foramen ovale, and we think there's about 4 million sport divers in the United States, clearly the prevalence of PFO does not relate to a high incidence of diving-related accidents or injuries from decompression. So it's not a contraindication, and I think that's something I'd like to be sure that people understand, because there's so many people there that are calling me to say that I want to get my PFO closed because I'm a diver, and if I put numbers to it, the risk of a decompression accident or decompression sickness in general with a PFO is about 3 or 4 in 10,000 dives, which is much lower than the risk for a complication from the PFO closure. So there's no particular reason to have a PFO closure in a diver just because it's there. There are rare cases where events occur that we can't explain, and occasionally a PFO closure will help in that. This is usually in extreme exposure type of diving, which is more commercial and military.
Is there anything else you think our audience needs to know about this fascinating topic?
Let me mention the implanted devices, because we're seeing more and more people with pacemakers and ICDs implanted who may have been a diver and want to go back. If you look at pacemakers, the companies generally test pacemakers under pressure to make sure they don't get damaged by the pressure. So there are instances where somebody with a pacemaker can go diving. Again, some of this relates to the underlying heart disease, and some of it relates to how healthy they are otherwise. But just the presence of a pacemaker is not necessarily a contraindication, all other things being equal. I don't particularly like the idea of people with ICDs diving for 2 reasons. One is they usually have significant heart disease, and 2, when an ICD fires, it causes a lot of disorientation, and sometimes underwater, if somebody has an ICD that fires, they could just get disoriented and drown in that circumstance. So I generally don't recommend an ICD, but some people with pacemakers can dive.
Is there anything else?
Well, I think overall, this is an interesting world in this topic, and oftentimes the need for somebody to tell a patient or an individual with a question about heart disease whether they're okay for diving. This could be a commercial diver or this could be a recreational diver. Generally, the military divers are handled by trained Navy diving officers, but I think that sometimes it gets a little too complicated. There is a group of experts that are board certified in undersea medicine, so sometimes if it gets to a commercial diving demand or something more complicated, the best is to refer to an individual who has some experience in this area.
I see. Thank you very much, Dr. Bove.